episodes of unprovoked seizure. Seizure involved sudden onset of uprolling of eyes, unresponsiveness lasted for 2 to 3 minutes with spontaneous recovery. No history of febrile illness, no history of trauma, no history of previous episodes of similar illness. Antenatal birth history was uneventful. Neonatal history, no NICU admission, no neonatal seizures, no neonatal hypobilirubinemia. Development was appropriate for age. This is the pedigree of the child. Child had presented with one episode of unprovoked seizure. Head-to-toe examination. Child was found to have multiple ash-leaf macules in left preauricular area, left chin, left anterior chest wall, left thigh, and right thigh. This figure shows multiple ash-leaf macule in the child. Systemic examination. Child was alert, active child with no focal neurological deficits. Other systemic examination was normal. And MRI brain done in the child showed multiple subcortical tumors and subependymal nodules. These figures shows multiple subependymal nodules. Other investigation done for the child, ultrasound abdomen and echo was normal. EEG done showed bihemispheric generalized epileptic activity. Ophthalmologic evaluation was normal. Child was treated with anti-epileptics and TSC1, TSC2 gene sequencing sent by next generation sequencing. To summarize, we have three different cases. A 5-month-old infant with infantile spasm, ash-leaf macules, multiple subcortical tubers and subependymal nodules. A 35-year female with seizures, ash-leaf macules, focal cortical dysplasia, having a fetus with cardiac rhabdomyosarcoma. And case 3, a 3-year-old child with one episode of unprovoked seizure with ash-leaf macule, multiple cortical tubers and subependymal nodules. This shows the pleiotropy of tuberous sclerosis. Coming to discussion, tuberous sclerosis complex. Tuberous sclerosis is a rare autosomal dominant single gene disorder due to mutation in either of two genes, TSC1 or TSC2. The incidence of tuberous sclerosis ranges between 1 in 6,000 to 1 in 10,000 live births. Tuberous sclerosis can affect any organ system and its manifestation can be associated with lifelong morbidity. Hence, early diagnosis and appropriate lifelong surveillance and management is crucial. And tuberous sclerosis has major criteria and minor criteria as diagnostic criteria. Major criteria, there are 11 major criteria and there are 7 minor criteria. It's a clinical diagnosis. Major criteria involves hypomelanotic macule, angiofibroma, ungual fibroma, Sjagren patch, multiple retinal hematomas, multiple cortical tubers, subependymal nodules, subependymal giant cell astrocytoma, cardiac rhabdomyoma, lymphangioliomyomatosis, and angiomyolipoma. Minor criteria involves conopity skin lesions, dental enamel pits, intraoral fibromas, retinal achromic patch, multiple renal cysts, non-renal hematomas, sclerotic bone lesions. Definitive diagnosis of tuberous sclerosis can be made by the presence of two major features or one major feature with two minor features. Possible TSC, either one major or more than or equal to two minor features. And genetic diagnosis can be made by finding a pathogenic variant in TSC1 or TSC2 gene. Coming to TSC gene, TSC1 gene located on chromosome 9q34 encodes for a protein called hamartin. TSC2 gene located on chromosome 16p13 encodes for a protein called tuberil. Hamartin and tuberin protein complex regulate mTOR pathway, which is a key signaling pathway involved in cell growth, metabolism, and proliferation. They modulate gene transcription and suppress tumor growth. Hence, they are basically tumor suppressor gene. When there is genetic variant in tuberous sclerosis gene, impaired function of tuberin and hamartin, which leads to aberrant activation of mTOR pathway, leading to abnormal cell growth and proliferation, resulting in non-cancerous tumors and hematomas. Variable expressivity of tuberous sclerosis complex. It's an extremely heterogeneous disease where the presentation varies from severe intellectual disability with intractable epilepsy to normal intelligence with lack of seizures. Spectrum varies interfamily and intrafamily. So, in tuberous sclerosis, we should see all the organ system and we should have lifelong surveillance. First, we should obtain 3-generation family pedigree and should counsel the parents for genetic diagnosis. And coming to other organ system, in nervous system, we should obtain MRI brain every 1 to 3 years. And in surgical resection of subependymal giant cell astrocytoma should be done. EEG should be taken every 6 weeks up to 12 months of age and every 3 months up to 24 months of age. Vigabatrin is recommended in first-line therapy for infantile spasm, anti-seizure medication for other types of seizures. Tuberous sclerosis associated neuropsychiatric disorder we should perform an annual TAN screening and we should refer the child to appropriate professional. In abdomen for kidney, we should obtain MRI of the abdomen every 1 to 3 years throughout the lifetime, and we should screen for hypertension, proteinuria annually. In lung, to rule out lymphangioliomyomatosis, we should perform a baseline CT, repeat CT screen once in 5 to 7 years. Dental screening should be done annually. Dermatological screening should be done annually. In heart, we should do a pediatric echocardiography every 1 to 3 years. For eye, we should do an annual ophthalmologic evaluation to rule out astrocytic hamartoma and achromatic patch. To conclude, the treatment of tuberous sclerosis, lifelong surveillance is first and foremost important. For dermatological manifestation, laser can be done for angiofibromas and mTOR inhibitors can be given. Topical rapamycin can be given. In brain, for infantile spasm, drug of choice is vigabatrin. Anticonvulsants for other type of seizures. When we have subependymal giant cell astrocytoma, we should look whether it is symptomatic or asymptomatic. In symptomatic case, we should go for surgical resection. If it causes obstructive hydrocephalus, we should go emergency neurosurgery. In asymptomatic cases, mTOR inhibitors can be tried. In renal system, for angiomyolipomas, if it is more than 3 cm, mTOR inhibitors is the first line of choice. If the angiomyolipoma is more than 3.5 cm, arterial embolization and surgical resection can be tried. In lung, lymphangiomyomatosis, mTOR inhibitor should be tried. To conclude, tuberous sclerosis is autosomal dominant disorder with variable expressivity and pleiotropism. Ashley-Mackuse is the earliest manifestation in tuberous sclerosis. Vigabatrin is the drug of choice for infantile spasm in tuberous sclerosis. EEG is indicated in a child with tuberous sclerosis even in the absence of seizures. Hips arrhythmia is a devastating rhythm severely affecting the development of the child. Vigabatrin optimizes the cognitive development in a child with tuberous sclerosis. mTOR inhibitors, sirolimus, everolimus are useful in some of the manifestations of tuberous sclerosis. The role of genetic testing is indicated in prenatal testing and to analyze risk in subsequent pregnancy. Thank you.
That was a very crisp and wonderful presentation, ma'am. And floor is open for discussion.
Good afternoon, ma'am. So, hello.
Hello.
Hello, ma'am. This is Dr. Hariharan, AP from Balaji.
Yes, yes, sir.
Thank you for the wonderful presentation. We just have few doubts. Like the first case, the child was treated with vigabatrin. How long was the child treated with vigabatrin, ma'am? Like
the child is still on vigabatrin, sir.
okay. Then if it is still on vigabatrin for a long course, has the child developed any adverse effects?
No, sir. The child is there is a regular ophthalmological examination is also done because of visual field defects. The child was already even baseline ophthalmological screening was done before starting vigabatrin, sir. In fact, the child is in follow-up in Chitra Tirunal now. Child is not here.
Okay. Our experience with the vigabatrin is very limited.
We started the vigabatrin, but for now they are in Kerala. Yes.
Yeah. Thank you, ma'am. Because our experience with vigabatrin is very limited. We just wanted to know. Thank you so much.
Yeah. Yes.
Nice presentation, ma'am. The second case, actually, the rhabdomyomas multiple were there. So what happened, ma'am? After it disappeared?
It regresses, sir. And that is the usual prognosis of fetal cardiac rhabdomyoma due to tuberous sclerosis, sir. It usually regresses, sir. Very rarely it causes output failures and arrhythmias, sir. But yeah, usually the prognosis is good for fetal cardiac rhabdomyomas.
Okay. So nice presentations actually. And this mTOR inhibitor, sirolimus, everolimus is a good take home to remember. Next to vigabatrin, yes, I think.
Yes, sir.
Thank you.
Thank you, sir.
Thank you. Hope it added a lot of points to the postgraduates. Without wasting much time, we'll move on to the next case presentation by Dr. Praveen from Chettinadu Hospital and Research Center. Dr. Praveen?
Good afternoon, ma'am.
Please share your slides. Dr. Gokila, please, can you end your slide share? Dr. Gokila,
Yes, ma'am.
please end your slides. No?
Yes, ma'am. You put in amount.
Dr. Praveen, over to you.
Yes. Good afternoon, ma'am, sir. Today, my topic is on decoding the overlap. Myself, Praveen, second year postgraduate from Department of Paediatrics from Chettinad Hospital and Research Institute. Case report, Jayashree, 13 years old female child came with complaints of joint pain and swelling for 6 months and weight loss for 6 months and exertional dyspnea for past 1 month. History on admission, the child was apparently normal 6 months back, after which she developed swelling of bilateral interphalangeal and intertarsal joints. It is on and off associated with pain, non-migratory, aggravated on using fingers, and a restriction of movements was present. And history of early morning stiffness in involved joints was present, and there were no relieving factors. History of fever on and off, which is low grade for past 6 months. Each episodes was limiting each lasting to 2 to 3 days with increasing frequency was present. History of significant weight loss.
Dr. Praveen, not audible. Dr. Praveen?
History of significant weight loss, lost 10 kgs in last 4 months with increase in tiredness and easy fatigability was present. History of palpitation for past 1 month, which is on and off aggravated on exertion. History of exertional dyspnea was present since 1 month, which was progressed from NIHA grade 1 to grade 2 over last 1 week, which is relieved with rest. And history of burning micturition for 4 days with increased frequency of micturition and lower abdomen pain was present. No history of night sweats, cough and cold or loss of appetite. No history of chest pain or syncope. No history of bleeding manifestation or jaundice. No history of skin rash, difficulty in walking, involuntary movements. No history of sore throat. No history of hair loss, oral ulcers. No history of abdomen distension or leg swelling. No history of hematuria, decreased urine output or frothy urine. No history of vision abnormalities or redness of eyes. No history of altered sensorium or abnormal behavior. Past history. For similar complaints, I was sent to from GH in December, where she was treated symptomatically with oral analgesics. On 29th of Jan, child was taken to National Institute of Siddha in Tamaram, where investigations were done and started on Siddha medications. Details were not available. On 24th of February, child was admitted at again at GH Kanjipuram for a cervical lymphadenopathy and treated with IV antibiotics. She was worked up for TB. Sputum AFB was done. There it was found to be negative, and CVNAT was not done. On 11th of March, child had acute gastroenteritis and treated on OPD basis. And antenatal history, birth history, and postnatal history were uneventful. Immunization history, immunized till 10 years of age according to NIS. And development history, child has normal growth and development, studying A standard with good scholastic performance. Family history, child is second one of a non-consanguineous marriage. No history of TB, asthma, or sudden deaths in family members. No history of malignancies in family members. And anthropometric child comes under severe illness. On general examination, on admission, child is conscious, oriented, mild pallor was present. No cyanosis, clubbing, uterus, or pedal. And respiratory rate was 24 per minute. Head to toe examination, generally the wasting was present, skin, pallor was present, BCG scar present, bilateral cervical lymph nodes present, largest measuring 1.5 cross 1 centimeter, non-tender firm nodes, bilateral central group of axillary nodes were present. Right side 2 cross 1 centimeter and the left side 1 cross 1 centimeter, non-tender mobile, no inguinal lymph nodes were palpable. Joint swelling and restricted range of movements of bilateral interphalangeal and intertarsal joints were present. A few papillar rashes noted over the swelling. Wasting of thenar and hypothenar remnants were present. And no oral ulcers, hair was normal, no malar or photosensitive rash, no peripheral markers of rheumatic fever, no peripheral markers of TB. In systemic examination, other systemic examination, CVS S1, S2 plus, no murmur heard. RS bilateral air entry was equal, no added sounds, per abdomen soft, bowel sounds present, and no organomegaly was present. CNS examination, higher mental functions was normal, cranial nerves no deficit, motor tone normal, power, minimal proximal muscle weakness was present. Child had difficulty in raising arms, and reflexes were normal. Sensory examination was found to be normal, no cerebellar symptoms, no involuntary movements, and the spine and cranium were found to be normal. Course in hospital, child admitted with the complaints of small joint arthritis, weight loss, and exertional dyspnea. On examination, child was found to have resting tachycardia, generalized lymphadenopathy, small joint arthritis, and a minimal proximal muscle weakness. The differential considered on day 1 were query rheumatic fever, in which points in favor of rheumatic fever are fever, painful tender joints, dyspnea on exertion. And second DD was tuberculosis. Child was malnourished child. Significant weight loss, about 10 kgs was lost in last 4 months with a significant lymph nodes was present. Fever for 6 months was present. And connective tissue disorder was suspected because child had fever, chronic small joint arthritis with the early morning stiffness, and minimal proximal muscle weakness, and dyspnea on exertion. On investigations we have done, leukopenia was present. Total count was 2,800 with a normocytic normochromic anemia. HB was 10.1. CRP was found to be reactive 19.06. LFT, RFT, serum electrolytes were found to be normal. On peripheral sphere, no atypical cells were seen. ECG and echo was done and showed no cardiac lesions or effusion. She was not fulfilling the Jones criteria. Cardiologist opinion obtained for progressive exertional dyspnea and tachycardia. Pericarditis were ruled out, and again repeat echo was done, which was found to be normal. Chest X-ray we have done, which showed minimal interstitial infiltrates was present. Child was treated symptomatically with oxygen and bed rest, improved spontaneously over 3 days. IUC thorax was done, pleural effusion was ruled out. She had mild epigastric pain during the course of hospital stay and was managed with proton pump inhibitors. Suspecting connective tissue disorder, investigation to look for other organ involvement was done. DCT was done, which was found to be single positive. Urine routine shows no hematuria or proteinuria. Dermatologist opinion for obtained for query Gottron papules and dermatomyositis. Nail bed capillaries showed no dilatation and the lesions were not classical of Gottron's papule as per dermatologist opinion. ANA profile we have done, which titer was found to be 106, in which RNPA, RNPC, and RNP6 with anti-ribosomal protein P0 were found to be positive. Considering the clinical history, examination findings with the lab evidence, a provisional diagnosis of mixed connective tissue disorder was made. Rheumatologist opinion was sought and started on steroids and DMARDs on 10th of April 25. Urine culture was sent since child had urinary complaints and which showed significant growth of E. coli, and child was started on IV antibiotics and IV gentamicin was started. After starting steroids and DMARDs, joint swelling and pain was significantly decreased. Mixed connective tissue disorder, it is a rare systemic autoimmune disease with at least 2 of the overlapping connective tissue diseases, including systemic lupus erythematosus, systemic sclerosis, polymyositis, dermatomyositis, and rheumatoid arthritis. The disease is also defined by presence of anti-U1 ribonucleoprotein antibodies and Raynaud phenomenon. Diagnostic criteria, this is the Kasukawa criteria, in which one common symptoms will be present. The common symptoms are Raynaud's phenomenon and swollen fingers, and presence of anti-RNP, anti-ribonuclear protein antibody, and the symptoms pertaining to SLE, systemic sclerosis or polymyositis, such as polyarthritis, adenopathies, malar rash, pericarditis, or pleuritis. And for systemic sclerosis, sclerodactyly, pulmonary fibrosis, or esophageal dilatation. For polymyositis, either muscle weakness, elevated muscle enzymes, or myogenic signs on EMG will be present. This is the most followed criteria. Pathophysiology, the etiology of mixed connective tissue disorder is unclear. The risk alleles for MCT are HLA-B08 and DRB1. 4 various protective alleles are DRB1 044 and DRB1 1301 and DRB1 1302. 2 main mechanisms have been proposed for the pathogenic role of anti-U1 RNP antibodies. First mechanism is direct binding to the endothelial cells through U1RNP peptides. This leads to vascular disease such as Raynaud phenomenon, skin sclerosis, and pulmonary hypertension. The second mechanism is immune complex formation, which causes tissue inflammation and causes myositis, arthritis, and interstitial lung disease. Common manifestations of skin are Raynaud phenomenon, which is most common. Puffy digits, nail bed capillary abnormalities may be present. In this child, puffy digits was present. In musculoskeletal system, patient may develop inflammatory arthritis similar to SLE or rheumatoid arthritis. In this child, inflammatory arthritis was present. Muscle. Inflammatory myopathy manifests as painless proximal muscle weakness with increased creatine kinase. In this child, minimal proximal muscle weakness was present. Pulmonary manifestation, dyspnea is the most common symptom. Other symptoms include dry cough, pleuritic chest pain, wheezing, and hemoptysis. Interstitial lung disease can also occur, and pulmonary hypertension. And cardiac manifestations, pericarditis, which is the most common variant. Pericardial effusion, mitral valve prolapse, myocarditis, and accelerated atherosclerosis and conduction abnormalities can also occur. Gastrointestinal symptoms are esophageal dysmotility, which can lead to dysphagia, odygophagia, gastrointestinal reflux, and regurgitation. The less common manifestations are in renal. Membranous nephropathy is the most common. In CNS, headaches, peripheral neuropathy, aseptic meningitis, cerebral venous sinus thrombosis, and sensory hearing loss may be present. Hematological involvement includes anemia, leukopenia, and thrombocytopenia may occur. In this child, both anemia and leukopenia. Evaluation, laboratory studies in CBC, the anemia and leukopenia may be present. Hypergammaglobulinemia is present in 75% of patients with mixed connective tissue disorder. ESR and CRP is elevated. In urine analysis, proteinuria and hematuria may be present. Immunological markers include high titers of anti-nuclear antibody, typically more than 1,280, and high titers of anti-U1RNP antibodies. The sensitivity of anti-ribonuclear protein antibodies is about 100%, but specificity is lower. Another potential markers include SM and survival of motor neuron antibody, and muscle enzymes may be elevated. For cardiopulmonary testing, chest X-ray screening test for lung disease for checking pulmonary infiltrates, interstitial lung disease, and pulmonary effusion and cardiomegaly. CT may be helps in diagnosing interstitial lung disease. Echo may be used for screening for right heart disease and pulmonary hypertension and for assessing the overall cardiac function. Pulmonary function testing is to check the lung capacities, and right heart catheterization is used for diagnosing pulmonary hypertension. Musculoskeletal imaging, X-ray of joints may helps in identifying inflammatory arthritis with erosion, joint space narrowing, and periarticular osteopenia. Musculoskeletal ultrasound, which can diagnose soft tissues, cartilage, bone surfaces, and presence of abnormalities which are responsible for joint pain and swelling. MRI is used to evaluate inflammatory muscle disease or inflammatory arthritis. Treatment, there is no specific treatment for mixed connective tissue disorder. Pulmonary hypertension and interstitial lung disease is the main primary cause of morbidity and mortality. The main medication used to treat interstitial lung disease are mycophenolate mofetil, most preferred, cyclophosphamide, and rituximab. For pulmonary hypertension, vasodilators such as prostaglandins, epoprostenol, and endothelial receptor antagonists such as ambrisentan, and PD5 inhibitors such as sildenafil can be used. For Raynaud phenomenon, patient has to avoid caffeine, cold temperatures, and injury to digits. Oral calcium channel blockers such as nifedipine can be used. For arthritis, NSAIDs and hydroxychloroquine can be used. Pleuritis, pericarditis, myositis, and aseptic meningitis, and steroids can be given. For gastrointestinal reflux, proton pump inhibitors or histamine blockers can be given. Lifestyle changes and dietary modifications can be given. Thank you.
That was a very elaborate presentation. Thank you, Dr. Praveen. I welcome Dr. Panjabi Kesan sir, rheumatologist from SRM Global Hospital, to add a few words and more insight on the case. Welcome, sir.
Hello. It's a good presentation of MCTD in a childhood MCTD. 2 or 3 things. We'll start from the treatment. You said for arthritis, you said hydroxychloroquine and steroids and methotrexate to be added, because methotrexate is one of the drugs that can be given when the patient having MCTD and the predominant arthritis is there. When you make, is it not, sir? Okay. When you make a differential diagnosis in the beginning, when the patient a 12-year-old girl presenting with fever and arthritis. Did you think about the JAA also?
Yes, sir. We
Juvenile
have.
idiopathic arthritis?
Yes, sir.
What?
Yes, sir.
Because JAA is the one thing that can occur. That's a common disease. It's a rare disease. But anyhow, it's a good process. What I'm trying to say is in the beginning, when the patient is presenting with fever and arthritis, in the differential diagnosis, you should put JAA with systemic onset. And that patient having the type of fever. For example, the fever is whether it's quotidian or not. Like that, whether the rash was there during the peak of the fever is there or not. Like that, you have to put so that you can say it's no evidence for hepatosplenomegaly, lymphadenopathy, nothing is there. And what about the total count and then polymorph, like that, ferritin, whatever it may be. What I am trying to say is, in the beginning, when the patient is presenting with the fever and arthritis, first we will think about JAA of systemic onset. Then, of course, next thing is lupus. That's the one thing we'll think. The MCTD is the diagnosis of after investigation. With only UNRMP only, you can make a diagnosis of MCTD. Before that, you can very difficult because in MCTD, as you clearly said, arthritis, the rheumatoid factor also can be positive in 40 to 50% of the MCTD. Number one. Number two, ANA will be positive, as you said, in speckled pattern. You have to put it as specifically fine speckled pattern. That's the one thing, so that the differential comes. One is in speckled pattern, one is MCTD. And after that, uridine 1 ribonucleoprotein will be high. These are the investigation and the manifestation, as you said, one is arthritis, another one is scleroderma features, another one is myositis, another one is lupus features. But here in children, not like adults, the kidney involvement is rare, pulmonary hypertension is rare, lung involvement has occurred, but it's rare. Patient can have with myositis, mainly with puffy hand, with arthritis, with Raynaud's phenomena, and also the sometimes muscle weakness, sometimes the lupus manifestations of some of the manifestations like leukopenia is there. That's the lupus manifestation. The muscle weakness that can occur in lupus or in myositis also. Myositis also. Scleroderma features not much, where the esophageal involvement or skin tightening or Raynaud's or pulmonary hypertension, primary type without lung involvement or secondary type with lung involvement. So this patient had puffy hands, inflammatory arthritis, and only the lung involvement. Anyhow, the investigation, it shows clearly. See, all these criteria in adults, I don't think you can apply it in children. I don't remember that. Whether it be Kahn criteria or another one is also Selvia criteria or all those things. I don't think, yeah, that cannot be applied in children. But anyway, it's a good presentation. What is the treatment you are given to this patient? I go
for this child, hydroxychloroquine and methotrexate was started. Sir.
Yeah, that's what I'm telling you. Put it methotrexate, good. Hydroxychloroquine also. Only 2 drugs for the arthritis point of view. What is the anything else we are given for when the patient having a lung involvement? Methotrexate you can give, but you have to be careful about. You have to be careful about that. With the interstitial infiltrates are there. And what about steroids?
Steroids tablet prednisolone was started, sir.
Oral prednisolone only.
Oral prednisolone, sir.
Oral prednisolone, hydroxychloroquine. What is the dosage you are given hydroxychloroquine?
Sir, hydroxychloroquine, it was hydroxychloroquine started at 4 mg per kg per day, sir. It was initially started at 200 mg at night time, sir.
Okay. That's good. Hydroxychloroquine and methotrexate, and patient responded very well. Okay,
yes, sir.
That's fine. She is in follow up with you. We can develop most of the patient can develop scleroderma features after some months or years. That is an important thing, that the lupus patient, they respond very well to the treatment and they'll become all right also. The scleroderma features, one thing, in the long run, they can develop full-fledged scleroderma later on. Anyhow, thank you.
Thank you, sir.
Thank you, sir. Thank you, Punjab Kesan Rajan, sir. It was so nice of you. We wanted to make the discussion richer by getting the expert opinion. Hope we will try to get experts' opinion for all the presentations. Thank you, sir.
Balaji sir, Kritika here.
Yes, ma'am. Yes, ma'am.
Balaji, I have a few questions. Can I ask, or is it running late, sir?
Yes, ma'am. You can continue, ma'am. No problem.
So I just want to know how safe is to start steroids without doing a bone marrow, because the presentation was so confusing. This is first question. The next one is, what about the SMR for this child? And what is the importance in saying the wasting of thenar and hypothenar eminences? Because the child was totally like in thinness. Was there how to attach significance to especially pointing out that there is a thenar and hypothenar wasting?
Good
I mean,
afternoon, ma'am. This is Dr. Gayatri, assistant professor, ma'am, from CHRA. So this child initially presented with, so when she presented with fever and weight loss, one of her DDs were some malignancy also. So on repeated peripheral smear, we couldn't find any blast. And there was, in clinical examination also, there was no generalized lymphadenopathy or any hepatosplenomegaly as well. And more often it was looking more like a chronic illness. Associated inflammatory markers were also elevated. So that's why in case we didn't get any positive findings for any autoimmune disorders of this sort or rheumatological disorders, we were planning to do a bone marrow biopsy, ma'am. So since it was more towards a rheumatological condition, so we went ahead with steroids. But 3 times peripheral smear was repeated, and there were no blast or any malignant features. And her SMR was pre-adolescent stage only, ma'am. She didn't have any axillary or pubic hair, and TLRQ was also like stage 1 only. And
was there
one
any
more thing,
improvement with starting steroids or DMRDs?
right now she has a little bit of weight gain, ma'am, and she's afebrile. Joint symptoms have improved. Nutritional status like yet to follow up. She weight gain alone we have noted, ma'am.
What about the thenar and hypothenar?
Yes, ma'am. Actually, she had some proximal muscle weakness. During examination, we found out that she was not able to raise her hands overhead. So we were thinking some muscle involvement also. That's why we were thinking of more towards a mixed connective tissue disorder. Our initial DD was SLE, but since muscle involvement was also there, we were thinking of dermatomyositis. And some rash around her knuckles were also there, but not typically like Gottran's papules. So we did a nail bed capillaroscopy, ma'am, but there were no capillary dilatation. So since it was not fitting into fully of a dermatomyositis, but clinically she had muscle weakness. And since hypothenar wasting was there, we were thinking of some chronic muscle wasting. So that's why we wanted to look for all the antibodies, and this presentation will be seen in MCTD.
Okay, thank you.
Thank you.
Thank you, ma'am. Thank you for the well presented case and well worked up case. And moving on to the next presentation by Dr. Gautam from Melmarothur Adi Parashakti Institute of Medical Science. Dr. Gautam.
Good afternoon, ma'am. Good afternoon to everyone. Myself, Dr. Gautam from Melmarothur Adi Parashakti Institute of Medical Science. Here we got a case, a 26 days old female baby who's delivered a term baby delivered by elective LSCS due to indication of non-progression of labor. It is outborn baby weighing around 3.350 kg. No history of NSU admissions or no history of seizures. And following which child developed a complaints of fever on 26th day of life. Complaints of fever for 2 days and irritable cry for 1 day and poor feeding for 1 day. And the key findings, there was lethargy and child had intermittent irritable cry and persistent fever spikes was present. Retropolis was present and antifrontal were bulging. And in management, initial stabilization was done in ER and child was shifted to PSU. In view of suspected acute CNS infection, baby was started on empirical antibiotics immediately. And following which investigations were taken, and complete blood count was normal, and renal function test and serum electrolytes were normal, and CRP was elevated. In view of bulging anterior frontal, USG gradient done, which showed features suggestive of a neural sepsis, and for which a lumbar puncture was done, in which CSF showed protein was elevated and decreased glucose levels, and total WBC counts was also elevated, and blood culture and CSF culture showed no growth. And in view of based on lumbar puncture findings, bacterial meningitis was suspected, which was further confirmed by PCR report. PCR report CSF PCR was done, was found to have Streptococcus pneumoniae, and child was and antibiotics was hiked after elevation of antibodies, and after elevation of CRP, and antibiotics were hiked and continued for 28 days of life. And following the child was discharged, and child was followed after 3 months of admission, and child did not develop any neurological features, and hearing examination done was found to be normal. And we have got another case, 8-year-old female child came with complaints of fever for 4 days, and cough for 2 days, and decreased appetite for 2 days. And the child was initially treated in private clinic, and on the outside CBC report done showed thrombocytopenia, and dengue MS1 done outside was found to be weakly positive. And key findings: child was febrile, and tachypnea was present, and workup breathing was normal, and child was maintaining saturation room air. On day 2 of admission, child has increased workup breathing, and hypoxia was present. On auscultation, air entry was reduced on right side, and bilateral rupture was present. And following the child was shifted to PICU and started on HFNC and IV antibiotics and other supporting medications. Chest X-ray done showed increased bronchoscopy markings and infiltrates over right lower zone and left retrocardiac region. And CBC done showed total counts was reduced, leukopenia and thrombocytopenia was observed, which was improved over on day 7 of life. CRP done was elevated, and throat swab done. Throat swab for PCR done was found to have Streptococcus pneumoniae. And on day 5 of admission, child respiratory symptoms was improved, and child was weaned off from respiratory support, and IV antibiotics was continued for 7 days, and changed to oral antibiotics, and then child was discharged. And burden of Streptococcus pneumoniae. Pneumonia is a leading cause of pneumonia is a top infectious killer of young children worldwide. About 1 million children die each year from pneumococcal infections like pneumonia, meningitis, and sepsis. In 2019, pneumonia caused around 40,000 deaths in children under 5 age group. Around 14% of all death in this age group. Children 1 to 5 years age are especially affected with pneumonia, causing 22% of death in this group. And in India, around 43 million cases of pneumonia occur in children under 5 each year. India alone will account for 23% of global pneumonia burden, and Streptococcus pneumoniae causes about 30 to 40% of bacterial pneumonia in these children. Pneumococcal meningitis causes overall half of meningitis cases. It is also responsible for 1/3 of meningitis cases in children under 5 age group. And disease spectrum, Streptococcus pneumoniae causes disease ranging from asymptomatic nasopharyngeal carriage to invasive non-invasive pneumococcal disease. And less common pneumococcal disease include such as soft tissue infection, pyogenic arthritis, and osteomyelitis, and primary peritonitis, and salpingitis, and endocarditis, and acute otitis media. In immunocompromised children, pneumococcal bacteremia can cause disseminated intravascular coagulation and even death within 24 to 40 days if untreated. More than 90 subgroups of pneumococcus was identified. And discussion in meningitis, in 0 to 1 month, it is most common causative organism is E. coli and other gram-negative bacillus, and in late onset neonatal age group, E. coli and Klebsiella pneumoniae was most common causative organism, and in 1 to 3 months of age, E. coli, Klebsiella pneumoniae, and Enterobacterium salmonella was a major causative organisms, and 3 months to 5 years, Streptococcus pneumoniae, H. influenza, and Neisseria meningitis was most common causative organism, and 5 years to adult Streptococcus pneumoniae and Neisseria meningitis was most common organism. And clinical features in neonate it will have only subtle symptoms: lethargy, refusal to feed, and irritability, incessant cry, hypothermia, and altered mental status, persistent bulging for and seizures. lab investigation to find out meningitis in blood. We need to look for complete blood count, blood culture, and C-reactive proteins. And CSF opening pressure, appearance, and cell count should be noted. And CSF biochemistry, glucose, CSF glucose, and the ratio of glucose. Ratio CSF glucose and the serum glucose was to be obtained, and CSF protein was to be noted. And CSF microbiology, gram stain and acid pass bacilli, and CSF culture and CSF PCR ELISA can be done. In CSF study, in cells, in virus, it is usually around normal to increase up to 10 to 100 only. In bacteria, it may increase up to thousands. In mycobacterium, it was increased, but not more than 500. And fungal, it is usually normal or normal to 10 to 100 only. Predominant cell types in viruses, lymphocyte is predominant, and in bacteria, neutrophils is predominant, and mycobacterium, lymphocyte will be predominant. And fungal infections, mixed lymphocyte and neutrophils can be present. In protein, in virus, usually normal to 50 to 100, mildly elevated. In bacteria, protein was very much elevated. In mycobacterium, it is around 100 to 500. It may be higher. It may be higher in spinal arachnoiditis. And fungal, it is usually normal up to 100 to 5. Normal up to 100 to 500. Glucose CSF in virus in viral encephalitis. It is usually CSF glucose was normal. In bacteria, it is reduced less than 40% of less than 40% of blood glucose. And normal to CSF blood glucose ratio, it is around less than 0.6. In fungal, it is also normal or reduced, but not much reduced. In empirical antibiotic therapy, if in child less than 1 month of age, ampicillin plus third generation cephalosporin such as cefotaxime can be used, or ampicillin plus gentamicin can be used. In 1 month to 18 years, vancomycin plus third generation cephalosporin can be used. Either ceftriaxone or cefotaxime can be used. And duration of antibiotic therapy, if unspecified bacterial meningitis was suspected, 10 to 14 days of antibiotics should be continued. In Neisseria meningitis, it is around 5 to 7 days. In Haemophilus influenza, it is around 7 to 10 days. And the Streptococcus pneumoniae, it is 10 to 14 days. And the gram-negative bacilli and Pseudomonas meningitis was suspected. Antibiotic has to be continued for 21 to 28 days. Pneumonia, clinical features based on viral pneumonia, it is usually followed by URTA, and child was less toxic, and bees may be present. It is usually bilateral, affecting all lobes. Usually lasts for about 3 to 5 days and dissolves spontaneously. In the streptococcal meningitis, the child will be more toxic, and the disease progression will be rapid, and lobar pneumonia can be present. And if pneumonia affecting lower lobes, it can present with the gastrointestinal symptoms such as abdominal pain and vomiting. And staphylococcal pneumonia will cause more necrotizing pneumonia and severe infection and pneumatocyst formation and empyema. Atypical pneumonia will be look like more like a viral pneumonia. A child will not that much toxic, and diffuse lung involvement will be seen. And on diagnosis, X-ray should be taken, and CBC and X-ray should be taken only in very severe cases, and CBC and CRP can be done. Culture, blood culture, pleural fluid culture, and lung parenchymal culture can be done. If mycoplasma is suspected, cold agglutinin titers and PCR assays can be done. In the group A streptococcus was suspected, ASO titers and anti-DNS can be done. And pertussis was suspected, culture of nasopharynx secretion and PCR can be done. Virus, PCR can be done. In viral pneumonia, there is only hyperinflation with bilateral interstitial infiltrates and peribronchial coughing will be noted. If in case of bacterial pneumonia, lobar consultation can be present. And treatment, if a mild infection, oral amoxicillin can be given. Severe infection is suspected. If child is fully immunized and not severely ill, ampicillin or penicillin can be given. If a child is not fully immunized or severely ill, ceftriaxone or cefotaxime cephalosporin can be used. And suspected mycoplasma, and chlamydia infection, macrolide can be included. And suspected staphylococcal infection, vancomycin or clindamycin can be used. On complication, local complications such as pleural effusion, empyema, and pericarditis can be seen. And systemic complications such as meningitis, endocarditis, suppurative arthritis, and osteomyelitis can be seen. And in case of staph aureus and streptococcal pneumonia, streptococcus pyogenes, parapneumonic effusion and empyema can be seen. Management of complication includes antibiotics of 4 to 6 weeks, and drainage by tube thoracostomy can be done. For prevention, for prevention, pneumococcal vaccine can be given. Pneumococcal polysaccharide vaccine and pneumococcal conjugate vaccine can be given. Pneumococcal polysaccharide vaccine can be given in more than 2 years of more than 2 year old child only, and it doesn't clear the nasopharyngeal carriers. But in case of pneumococcal conjugate vaccine, a nasopharyngeal carrier can also be cleared, and so far now PCV10 and PCV13 is used. And national immunization schedule, we are currently using Pneumocil 10 valent vaccine. And take home message, the Streptococcus pneumoniae can be present in a variable presentation. In this case itself, usually if child is less than 28 days old, the most common organism is E. coli, is E. coli pneumonia. Is E. coli meningitis, but in this case we found out that there is a Streptococcus pneumoniae, and in mostly Streptococcal, mostly pneumonia causing organism will cause pneumonia in less than 5 years of less than 5 year old children. But in this case, the 8-year-old female child can have got a pneumococcal infection, and we need to identify the early identification of cases should be done, and high risk cases should be vaccinated, and routine immunization should be done. Thank you.
Thank you, Dr. Praveen. That's a wonderful and detailed presentation. Floor is open for discussion.
This is Kritika again from Balaji. Thank you,
Yes,
doctor,
ma'am.
for a very wonderful presentation. I just want to know the timeline of the occurrence of these diseases, because why I am interested is at present we are treating a pneumococcal meningitis in our hospital. So would like to know if there is a little bit of surge. So I need to know the timeline of these and also the vaccination status of the second child. Was the child previously vaccinated or?
The second child was previously vaccinated only, ma'am. Vaccinated till 5 years of age, ma'am.
No, see, that child is 8 years old, right? At 8 years, in national schedule, the pneumococcal vaccine was not there. Was the child given like in private?
No.
More so, it carries very much importance, because even after vaccination, if the child develops pneumococcal infection, did you attempt to do any serotyping?
First thing,
Because
actually,
I
the first
heard.
baby, the first baby, both the
Okay.
babies, they presented 3 months back, ma'am. So the first baby
Okay.
was a neonate, and now after 3.5 months, the baby right now neurodevelopmental and growth wise normal, ma'am. And really the first baby, and the first baby actually, I mean, about the second baby, second child, she was not actually vaccinated with the
Yeah,
pneumococcal.
okay.
That's the
Okay.
thing. And serotyping actually, we tried, but
Because we heard, like we tried for this child, because I
yes.
heard that it was done only in CMC Vellore.
CMC Vellore
So
only, yes.
if anybody in the August gathering could like know somebody who could do a serotyping, like it would be for academical purpose. Please let us know about it. Okay.
Ma'am, Dr. Alexander here, right?
Okay.
You
Yes.
can contact Dr. Winsley Rose, Professor Winsley Rose at CMC. I think
Okay, sir.
he is under this, and he can take up this serotyping with, particularly with Streptococcus pneumonia.
Okay, sir. Sir, private message, like, can you share this number,
Yeah,
sir? It will
please,
be.
yes, madam. Yeah.
Okay.
Because
Okay,
as you
sir.
rightly pointed out, those 2 cases. So after
Okay.
introduction of this PCV10 into the national immunization schedule, we see to that the cases has come down. But now both the institute, you are saying that 2 to 3 cases you are notifying it. That's a great thing.
We are
And
seeing, sir, we are seeing huge number of cases, sir. In spite
oh,
of
great.
the national schedule, Nemosil, a lot
Then
of
there should,
big
yeah.
batches are
Then
So
there
that
should be
is
a
why
big
we
question
need to
mark on its
attempt.
activity.
Yeah. Serotyping is a must. Then it becomes very
Yes,
essential, sir.
Yes.
exactly, ma'am.
We got the tubes also, ma'am, from CMC Vellore, sir gave actually. So
Okay, sir.
you can contact ma'am. He gives the tubes. He does the
Okay.
serotyping.
Thank you. Thanks a lot, sir.
do, ma'am.
Thanks a lot for this information, sir. Thank you.
And one more thing I would like to say that nowadays, from the last few days, we started to use this pneumococcal vaccine, which is 14 valent, right? So nowadays, this PCV10 in NIS has been removed. Now the newcomer is PCV14. I hope that many
Okay.
of you might be knowing. Maybe let's see the impact of this PCV14 rather than on this PCV10.
Okay, okay, sir. Thank you.
Yes, recently it has been started on PCV 14.
But the
I hope so
problem
many
with
of
that
you.
PCV 14 is there is no studies for the boosters that are available till date, sir.
Exactly, madam. Because even for pneumo, this 10 valent also, we don't have any booster studies actually. But maybe in a year or two, I think they will tell it because studies are still ongoing only.
Okay, sir. Thanks. Thank you, sir.
Yeah,
Thank you.
yeah.
Thank you, sir. Thank you. Thank you, ma'am.
Thank you, sir. We'll move on to the last presentation by Dr. Sundar from Sri Balaji Medical College. Brittle but bright, crackling the code of pycnodysostsis.
Morning, ma'am. Ma'am, am I audible, ma'am?
You're audible. You can proceed.
Audible, ma'am?
Yes, doctor, we can hear you.
Good afternoon.
Hello.
Title is from Sri Balaji College, ma'am. My title is Brittle but Bright, Cracking the Code of Pycnodysostsis. Tallest slot in, ma'am.
Dr. Sundar, your voice is breaking actually.
4 years old.
Your voice is
On to a
breaking.
Ma'am, is it clear now, ma'am?
Yes.
Clear. Ma'am?
Dr. Sundar, we cannot hear you.
Ma'am, is it?
No problem.
Ma'am, is it clear?
Dr.
Yes, sir.
Sundar, I think we can hear you right now.
Ma'am, am I audible now, ma'am?
Yes.
Progress. Yes, ma'am. 4-year-old male child, third order born to a non-contact marriage. Milestone, large head, noisy breathing since birth, ma'am. No history of difficulty in breathing, dyspnea on exertion, ma'am. No history of weakness in limbs, altered sensorium, seizures. No history of trauma. No history of visual or hearing abnormalities. Past history, no previous history of hospitalization, no history of nebulization, no history of fractures, trauma, no history of recurrent respiratory conditions. Birth is even uneventful, ma'am. Immunization history, immunized up to the age according to national immunization schedule. Developmental history, gross motor, head control attained by 11 months of age, roll attained by 2 years of age, sat with support by 2 years, 6 months of age, walked with support by 2 years, 9 months of age, walked without support by 3 years of age. Developmental coefficient for gross motor is 60%. Fine motor, language, social adaptive milestones were appropriate for the age. Family history, no history of similar disorders in the family. anthropometry, height 80 centimeters corresponds to -3 standard deviations of Z-score growth charts. Weight is 10.15 kg, corresponds to -3 standard deviations. Head circumference is 51, corresponds to 0 to +1 standard deviations. Weight for height corresponds to 0 to -1 standard deviations. Upper segment, lower segment ratio came to be 1.5:1, which is suggestive of disproportionate short stature. Vitals of normal. General examination, child is active, alert, afebrile, pallor present, no icterus clubbing cyanosis, no lymphadenopathy. Head to toe examination, head brachycephaly is present, anterior fontanelle, posterior fontanelle wide open, sutures unfused, large and wide palpebral fissures with biparietal enlargement and frontal parietal bossing. A nice esophagus is present, oral cavity, dental malalignment present. Abdomen, pot belly, there is protruded abdomen is present. Pectus excavatum, Harrison sulcus present. No racket glossary. Extremities, short and stubby fingers, left polydactyly present. Pes planus, that is flat foot with prominent calcaneum is present. No neurocutaneous markers, no grooved nails. Both arm and forearm are normal. External genitalia is normal. Deep tendon
Dr. Sundar,
reflection,
your
superficial
slides are
reflection
not
normal.
moving. Dr. Sundar, your slides are not moving. Yeah.
Okay, ma'am.
You may continue. You may continue.
Abdomen is normal, respiratory system is normal, CVS is normal. Can you see this?
Examining slide only. The voice is also not coming back. Sir.
You can go and do somewhere there.
Yes, ma'am. Ma'am, is it moving, ma'am?
Yes.
Hello.
Hello, ma'am. We can see that. We can continue, ma'am.
Yes.
The slide sets are moving appropriately.
Investigations, chest X-ray, AP showing typical AP view showing typical hypoplastic clavicles. Right lateral view of lumbosacral spine showing dense vertebral bodies with sparing of transfer processes. X-ray skull showing lateral radiograph showing wide open fontanelles, obtusely angled mandible and Wormian bones. X-ray of hand AP radiograph shows acroosteolysis, medullary expansion of distal radius, remodeled and narrowed terminal phalanges with left polydactyly. Skeletal survey. Dense bones, open fontanelles and sutures, hypoplastic, obtuse angled mandible and Wormian bones are there. Frontal bossing and parietal bossing is present. Dense vertebral bones with sparing of transverse processes, hypoplastic clavicles. CBC HB is 9.9 and rest all parameters were normal. Serum creatinine and urea, BN was normal, ALP was normal, vitamin D levels were normal. MRI brain showing bilateral supratentorial lateral and third ventricular dilated. Fourth ventricular is prominent. Sulcus space is abnormally prominent for the age. With these skeletal survey and investigations, we've concluded to differential diagnosis of osteopetrosis pectinodissostosis. Ophthalmology opinion was sorted and came to be normal. ENT opinion was sorted and came to be normal. Speech is normal for the age. USG abdomen was normal. 2D echogram was normal. The differential diagnosis were pycnodysostiosis, osteopetrosis, dysosteosclerosis, spondyloepiphyseal dysplasias, and rickets. Genetic testing was done. Whole exome sequencing report came to be pycnodysostiosis pathogenic variant, autosomal recessive mutation within exon 5 of CTSK gene. Diagnosis is made by clinical and radiological features, confirmatory tests, whole exome sequencing. There are few specific tests for pycnodysostiosis, which are targeted CTSK gene sequencing, multi-gene panel testing, carrier testing, and prenatal diagnosis. Management. There is no specific curative therapy for pycnodysostiosis. Multidisciplinary approach is needed, supportive and symptomatic care, genetic counseling for the family. Growth hormone therapy was advised, but the patients are not affordable. Physiotherapy for strengthening exercises to all the limbs, breathing exercises, pelvic bridging exercises. Occupational therapy was offered. Early and regular dental follow-up, dental procedure for malalignment of teeth. Educate parents for prevention, orthopedic surveillance for recurrent fractures, ENT follow-up for sleep apnea and mouth breathing, calcium and vitamin D supplementation. Discussion. Pycnodysostiosis is a rare genetic disorder with an incidence of 1 in 1 million, which is autosomal recessive disease, which means that both the parents must carry the defective gene for the child to be affected. Cathepsin K is a lysosomal enzyme critical for osteoclast-mediated bone resorption, which is deficient here. A high amount of suction is required to make the diagnosis, which needs to be made primarily based on the clinical findings. Radiological imaging helps in further affirming the diagnosis by showing increased bone density, notably seen in the skull and long bones. Main features of the disease include osteosclerosis, acroosteolysis, and disproportionate short stature, all of which were present in our case. Other notable features which were seen were brachydactyly with grooved nails, dental anomalies. Confirmatory tests include testing for a mutation in CTSK gene. Several other diseases such as osteopetrosis, hypoparathyroidism, and cleidocranial dysplasia are to be ruled out while diagnosing the disease. As there is no well-defined primary care, the child is treated with supportive therapy. Even though it is known to have no impact on life expectancy, regular follow-up with the pediatrician as the primary team and intervention with orthopedics and oromaxillary facial surgeons is essential for the long-term complications. Follow-up with pediatric endocrinologists for the growth hormone therapy may be required for some children with short stature. It is shown to have a good response if started early. Research in enzyme and gene replacement therapy may help in potential treatment options in the future. Conclusion. Pycnodysostiosis is a well-characterized genetic disorder with distinctive features and clear genetic cause. With no known cure for the disease, supportive measures can help in managing the symptoms and improving the quality of life for the children. Once identified, adequate checkups along the proper family genetic counseling required. Potential research in this area may provide some hope for the affected individuals and their family. Thank you.
Thank you, Doctor, for presenting such a rare case. I welcome Dr. Gautaman sir, pediatric orthopedician from SR Medical College, to add few words on this case.
Yeah, good afternoon all. I really want to appreciate your team for diagnosing this lysosomal storage disease. And as you mentioned before, the different diagnosis like osteopetrosis, and which is very commonly seen in recent time. It is very difficult to differentiate between both this. And few more points I just want to add for the treatment part. It is actually better to give some spinal braces for the child, because the child easily develops scoliosis, pathological fractures and scoliosis. What is the age of child, ma'am? May I know the age of child, please?
4 years.
4 years.
Okay. I think the child weight of the child is around 10.5 kgs. So when the child gains weight,
Yes.
maybe around 20 kgs, the child will develop pathological fractures. So it's better to brace this, sprint the spine so that we can easily avoid those scoliotic deformities. And child won't develop fractures now. When the child starts developing, gain weight, he will definitely get fractures. So for that, we have to have proper follow-up. And as you mentioned, growth hormone therapy really helps, it seems. This is the first case I'm encountering it, but I referred few articles which mentioned growth hormone therapy really helps, so that the child will have a adequate height during his development. And yeah, that is what I want to mention. Thank you for the discussion.
I am Dr. Sundar from Balaji. One more point I would like to add is many cases of osteopetrosis and pycnodysostoses used to come to ICH when I was there. Our radiologist, Dr. Elizabeth, senior radiologist, very good radiologist, immediately by just taking the band will say osteopetrosis. The hallmark of distinguishing osteopetrosis from pycnodysostoses is thickening of the lamina dura, which is the membrane present around the tooth. So if the lamina dura is so thick and visible radiologically, then you can dogmatically say it's osteopetrosis. So just with an X-ray of the mandible, you can make a distinguishing diagnosis between osteopetrosis and pycnodysostoses.
Yeah, one more point I just want to add is that there will be ill-defined corticomedullary differentiation in X-rays in all long bones. So that is a very important point, should be noted in this.
Any doubts further?
Thank you. Nice presentation. With regards to growth hormone, I think skeletal dysplasias, the growth hormone might not be that effective. We need a good growth plate to affect.
This is not a skeletal dysplasia. It is a lysosomal storage disease. So growth hormone is recommended, and the government sponsoring many cases of like Gauchers, Niemann-Picks, like that. They are also sponsoring like Hallers, Morchios. They are sponsoring even for pycnodysostoses. It's a lysosomal storage disorder.
Thank you. And the difference between pycnodysostoses and osteopetrosis, maybe we can highlight that.
Both have usually thick bones, but both are associated with fractures. But bone marrow infiltration is more in osteopetrosis. As a result, you get pancytopenia, and all the foramina in the brain, like where the optic nerve comes out, the eighth nerve comes out, are all pressurized. These nerves are under pressure due to the deposition of this bony material and defective osteoclastic reabsorption. So blindness or vision may be affected in osteopetrosis, and also hearing can be affected in osteopetrosis. And if you take the X-ray of the hand, terminal phalanx will have acroosteolysis, which is typical of pycnodysostoses, which is not seen in osteopetrosis.
Thank you, ma'am. I think as madam says, these are the take-home points. For osteopetrosis, the bone marrow pancytopenia will be there, and optic nerve and other cranial nerves involvement will be there. And this acroosteolysis is a good take-home point for pycnodysostoses. Thank you, ma'am. Thank you for the good presentation. Thank you. He is our pediatric orthopedician actually. So we thought we should enrich the discussion. So we called upon, and others also can.
Thank you for.
Thank you, sir. Thank you, ma'am. Thank you, ma'am.
Thank you for calling orthopedician.
As of now, if we have no doubts, we can wrap the session. I thank all the institute and the postgraduate faculties, HODs for taking a lot of effort in bringing out interesting cases and adding a more of learning points. Thank you. Thanks a lot.